Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the Pursue series. As you are aware, all our lectures are available on YouTube. You can easily download them, view them at your convenience. Best is to go to the playlist where you can view all the lectures chapter wise. We also have a Telegram group which you can join, which is very helpful in accessing all lecture related information. We have a Google Drive where the PDF of all the lectures are available. These are arranged Pursue wise, so you can go to the specific Pursue and view all the lectures of that particular chapter. These are the disclaimers. We are in phase 3, which is recorded pathology lectures, and today we are with Pursue 9U, which is cytopathology, and we are streaming from the picturesque Department of Pathology, Dr. YSPGMC, Nahan, Himachal Pradesh. And to talk on today's topic, which is Cytology of Thyroid, which is Basics and Bethesda 1 and 2, we have Dr. Sudha Sharma. She is an MD from PGI Chandigarh, DNB in Pathology. Presently, she is an Assistant Professor in the Department of Pathology at the Dr. YSP Government Medical College, Nahan, Himachal Pradesh. Her areas of interest is cytopathology and gynecological pathology. She's got multiple publications in national and international journals. She's also the life member of IAC and IAPM. With this, let me request Dr. Sudha Sharma. Ma'am, please start your lecture on cytology of thyroid. This is session 1, which will be dealing with basics as well as Bethesda 1 and 2. Over to you, ma'am. Thank you so much.
Good morning, everyone. This is my first lecture on thyroid cytology, and today I'll be talking on the basics of thyroid cytology, Bethesda System, and we'll talk in detail about Bethesda 1 and 2. So this is my outline, the outline of my talk. I'll briefly introduce the topic, followed by technique and prerequisites for thyroid FNAC, approach to thyroid FNAC, Bethesda System for thyroid cytology, and in detail we'll discuss about Bethesda 1 and 2. So thyroid nodules, if we screen the general population, they can be detected on ultrasound in up to 50% of the general population. And they are more common in women. However, the good news is that only about 5% of these nodules will harbor a malignancy. So 90 to 95% of the thyroid nodules will be benign. So why is thyroid FNAC important? Because it reduces the rate of unnecessary thyroid surgery in a patient with a benign nodule. As we have seen, 90 to 95% of the nodules will be benign. So on FNAC itself, we can screen the patients who do not need a thyroid surgery. The consensus guidelines from the Endocrine Society of India strongly recommends evaluation of all thyroid nodules more than 1 centimeter, including both palpable and radiologically distinct non-palpable nodules. So whenever we have a thyroid nodule, we should have a differential diagnosis in mind. We have seen 90 to 95% of these nodules will be benign. So most of them will be either a colloid nodule, adenomatous nodule, follicular adenomas, or thyroiditis. 5 to 10% will be malignant, and of these 90% of the malignancies are well differentiated malignancies. Only about 5% of malignancies are poorly differentiated or anaplastic carcinomas. So among the well differentiated malignancies, most common are papillary carcinomas constituting 75% of tumors, followed by follicular carcinomas, medullary carcinomas. Then we can have lymphomas in thyroid, and we can have metastasis to the thyroid. In addition, we can also have developmental anomalies of the thyroid which can present as a thyroid nodule, like unilateral lobe agenesis or thyroglossal duct cyst. So before doing a thyroid FNAC, there are some prerequisites which we should follow. Have a detailed history of the patient, detailed clinical examination, and look for the neck nodes. In the history, we should know about the age of the patient and sex of the patient. Why? Because goiters or benign nodules mostly are seen in younger ages, in teenage, whereas anaplastic carcinomas and lymphomas are mostly seen in elderly age. Papillary carcinomas are usually seen in young females. Duration of the thyroid swelling is important because if the swelling is present since birth, we can think of a thyroglossal cyst. If the swelling is recently arisen and it is of short duration. The history is typical of anaplastic carcinomas or lymphomas. History of pain is important. It indicates towards thyroiditis. Ultrasound findings are important. We'll discuss about them in detail later. Thyroid profile is important because if a patient is hyperthyroid, there are chances he can go on in a thyroid storm when we do FNAC. So thyroid profile is important. Drug and family history is important because some drugs like lithium, amiodarone, they can cause thyroid dysfunction. So detailed drug history, family history of any carcinoma of the thyroid. Previously, it was thought that medullary carcinomas are familial, but now even papillary carcinomas have been seen to run in successive generations. So detailed drug and family history should be taken. History of radiation exposure should be taken because in these patients having history of radiation exposure to the neck at a young age are predisposed to develop papillary carcinomas. However, the incidence of radiation exposure in young age has now decreased, but still history has to be taken. On clinical examination, we should note the size of the thyroid, whether it is diffuse, nodular, or multi-single nodule or multiple nodules. Consistency of the thyroid, whether it is soft, firm, or hard. Typically, a hard thyroid, it can be seen in case of Riedl's thyroiditis. Fixity of the thyroid and also fixity of the thyroid indicates that the thyroid is fixed to the surrounding regions. So that itself indicates that it can be a malignant lesion. However, in case of Riedl's thyroiditis, also the thyroid may be fixed to the surrounding structures. You should look for cervical lymph nodes on palpation as well as on ultrasonography because in malignancies, cervical lymph nodes are more common. Among the papillary and follicular carcinomas are commonly involve the cervical lymph nodes. Avoid performing FNAC on a patient who is fasting. Ensure that the FNAC request form has been filled thoroughly. The patient's age, details, history, clinical examination, ultrasound findings, and uh, the clinical diagnosis has been mentioned on the request form. Consent form you have to take and take the patient's sign. Explain the procedure to the patient thoroughly. Take any history of any bleeding disorder. The 2015 American Thyroid Association Management Guidelines, they recommend ultrasound guided FNAC for these lesions. In case of non-palpable nodules which are located posteriorly, ultrasound guided FNAC should be done. In case of cystic nodules, where the cystic component is more than 25%, their FNAC should be ultrasound guided to reach the solid component. If the previous FNAC is non-diagnostic, go for ultrasound guided FNAC. And thyroid nodules in children, go for ultrasound guided FNAC. How in India, most of the FNACs, they are done unguided because they are mostly cost effective. So coming to the radiology, radiology has an important role in the classification of thyroid nodules, and the classification of thyroid nodules on ultrasound is based on Thyroid System. Thyroid System is thyroid imaging, reporting and data system. So this Thyroid System was given by ACR, that is American College of Radiology. There are various thyroid systems. However, the thyroid system given by American College of Radiology is widely followed, and this thyroid system, it has been adopted from the BI-RADS system, which was for the ultrasonography of breast lesions. So what is this thyroid system? So according to the thyroid system, the radiologic lesions, they are assessed based on their composition, echogenicity, their shape, margins, and any echogenic foci. So based on these parameters, the lesions of thyroid or the nodules of thyroid, they are given various points. And based on the number of points scored, the thyroid scoring is done from TR1 to TR5, where TR1 is benign and TR5 is highly suspicious. So thyroid scoring, it can guide whether FNAC needs to be done in a particular patient or not. For example, TR1 and TR2 lesions, no FNAC is required. Whereas for TR5 lesions, FNAC is required even for 1 centimeter lesion. And if a lesion is 0.5 centimeters, follow-up is required. So this was about the radiologic findings and assessment of thyroid on radiology. So coming to technique of FNAC. For doing FNAC, we can either do ultrasound guided aspiration or we can do aspiration by palpation method. In palpation method, we directly palpate the lesion and do the aspiration cytology, which can be either aspiration by aspiration method or non-aspiration method. So this is similar to the routine FNAC that we do. In aspiration method, usually it is ideal for cystic lesions where we aspirate the cyst fluid with the help of a syringe. Whereas in non-aspiration technique, we use a needle and directly needle the lesion and take out the aspirate. So positioning of the patient for FNAC is important. The patient should be told about the procedure in detail. The neck should be extended. Ideally, a pillow should be placed below the shoulder blade so that the neck is extended and the swelling is clearly visible on the neck. The patient should be instructed not to swallow anything so that the swelling does not move. Clean the swelling, fix it with your 2 fingers so that it doesn't move. Then take a thin needle, preferably 23 to 24 gauge needle, and aspirate the swelling. Take at least 2 to 3 passes, but the procedure should be quick. You should quickly, in within seconds, 1 to 2 seconds, you should aspirate the material and take it out, because thyroid is a vascular organ, so there are high chances of hematoma formation. So the procedure should be quick, otherwise you will get blood. So this method can be by palpation method or by ultrasound guided aspiration. In ultrasound guided aspiration, we use a probe which is used to guide the needle in the thyroid, and then we can take out the aspirate. Usually 22 to 25 gauge needle is used, and we take 2 to 3 punctures per nodule in different directions. If fluid is aspirated in FNAC, we should centrifuge this fluid and then take the sediment and smear it on the slides. In case there is a residual swelling after we have aspirated the fluid, re-aspirate it, and after complete evacuation, re-aspirate it and then again smear the residual material. In case of suspected malignancies, we can take a cell block for any ancillary studies. We can aspirate different types of material on FNAC. It can be blood mixed material. We can get thick and thin colloid. We can get cyst fluid, or we can get particulate material in case of neoplasms. Once we have made the smears, we should fix it in 95% alcohol, or we can air dry it, and PAP and MGG should be performed in all cases. So coming to interpretation of the smear. So whenever we interpret a thyroid smear, the rule of thumb is we look for these 2 things. We look for colloid and we look for the follicular epithelial cells. So the rule is that if we have increased more abundant colloid and less of cells, it usually indicates a benign pathology. And if we have abundant cells and less of colloid, it indicates towards the neoplastic pathology. However, this is not a short rule. We have, as with many rules, we have exceptions to this rule also. So we can have high cellularity in case of hyperplastic nodules. However, if you have abundant colloid, you should think of a benign pathology. And especially if you have thin colloid, then you should think of benign pathology. You can have thick colloid in case of papillary carcinomas. So how to examine a slide? Whenever we get a slide, we have to look for 3 things: cellularity, architecture, and the background. So cellularity means we have to see whether a slide has low cellularity, moderate cellularity, or high cellularity. So this cellularity is objective thing. You have to compare these cases. Second is architecture. So architecture means the arrangement of cells among each other. So how other cells arranged among each other. So if you have microfollicles, they indicate towards a follicular neoplasm. What are microfollicles? Microfollicles are when you have less than 15 follicular epithelial cells arranged in at least 2/3 of a circle. Then they are known as microfollicles. And they may or may not have colloid inside the lumen. So in architecture, we can either have microfollicular arrangement or we can have flat honeycomb sheets. So these flat honeycomb sheets, they can be seen in a colloid nodule. There is maintenance of polarity and there is adequate spacing in between the follicular epithelial cells. No overlapping is seen. So these are flat honeycomb sheets. Or the cells can be arranged in syncytial sheets forming papillary structures where there is nuclear overlapping and crowding. So if you have such a papillary structure with nuclear overlapping, crowding, think of a papillary thyroid carcinoma. And if you have two cell populations where one is looking malignant, the other is looking benign, think of a metastatic carcinoma. The third thing we have talked about is the background. To look of the background, look for colloid. Look for the amount of colloid, if you have abundant colloid or only some amount of colloid, and the texture of colloid, whether it is thick colloid or thin colloid. So I told you thin colloid is mostly seen in benign lesions, whereas thick colloid can be seen in papillary thyroid carcinoma. Then look for the macrophages or any granular material indicates any cystic change. For example, colloid goiter can have cystic change, and then you can see multiple macrophages along with granular material in the aspirate. If you have abundant lymphocytes, and some of which may be infiltrating the follicular epithelial cells, look for lymphocytic thyroiditis. So once we have examined the slide in low power, go to high power. In high power, we have to look for the cytomorphology of the cells, nucleus as well as the cytoplasm. So in the cytoplasm, you can get fire flaring. Fire flaring can be seen in neoplastic lesions as well as in non-neoplastic lesions. It does not indicate that the lesion is non-neoplastic. Then you can get Hurdle cells. Hurdle cells can show anisonucleosis and they have abundant eosinophilic granular cytoplasm. Prominent nucleolus can be seen. When we look for the nuclear features of papillary thyroid carcinoma should be looked for. And nuclear features of papillary thyroid carcinoma are nuclear clearing, nuclear grooving, and intracytoplasmic nuclear inclusions. And look for nuclear overlapping and crowding. Medullary thyroid carcinoma is a carcinoma of the C cells of thyroid, does not arise from the follicular cells, and here they have neuroendocrine features with salt and pepper chromatin and granular cytoplasm. So coming to approach to a thyroid nodule, whenever you have a thyroid nodule, you need to categorize it as benign or malignant. So benign lesions, we have seen 90%, 90 to 95% lesions are benign. Among the benign lesions, you can have non-neoplastic or neoplastic lesions. Non-neoplastic lesions can be colloid nodules or thyroiditis, most common of which is Hashimoto's thyroiditis. And among the neoplastic lesions, we have follicular adenomas and Hurdle cell adenomas. In the malignant lesions, we have well-differentiated malignancies like papillary carcinoma and follicular carcinoma, and poorly differentiated carcinomas like anaplastic carcinomas, insular carcinomas, and then we have medullary carcinomas which arises from the C cells of the thyroid. We can have lymphomas of the thyroid, we can have metastasis from other organs. Please note that we cannot diagnose follicular adenoma, Hurdle cell adenoma, or follicular carcinoma on FNAC because for the diagnosis of these lesions, we require capsular or vascular invasion, which cannot be seen on FNAC. So histopathology is required for the diagnosis of these lesions. And on FNAC, we only give a diagnosis of follicular neoplasm. NIFTP is a new entity which has been introduced in the Bethesda, revised Bethesda system. NIFTP is non-invasive follicular thyroid neoplasm with papillary-like nuclear features. So these are the diagnostic criteria for NIFTP. So as the name indicates, it is non-invasive. So we require an encapsulated lesion for the definitive diagnosis. It is a follicular thyroid neoplasm. So it will have follicular growth pattern and it will have papillary-like nuclear features. So it will have some papillary features, but the papillary features are not fully developed. So we can only suspect this entity on FNAC, looking at the follicular pattern as well as the nuclear features, but the definitive diagnosis of NIFTP cannot be given on FNAC because definitive diagnosis requires encapsulation of the lesion and it requires that there should be no vascular or capsular invasion. So definitive diagnosis is given on HNE, but we can suspect it on cytology, and usually these lesions NIFTP will be categorized into any of these three categories depending upon the amount of nuclear and architectural abnormalities. It can be categorized as follicular neoplasm, suspicious of malignancy, or atypia of undetermined significance. So coming to the Bethesda system for reporting of thyroid cytology. So before the Bethesda system, we had multiple reporting classifications, but none of them were accepted internationally. The Bethesda system, why was it needed? Because variable terminologies were there for reporting thyroid FNAC from lab to lab, which created confusion and it hindered meaningful data. So the National Cancer Institute, it hosted in 2007, the NCI Thyroid FNA State of the Science Conference at Bethesda, Maryland. And in 2007, the Bethesda System for Reporting Thyroid Cytopathology was published, and this established a standardized reporting system with a limited number of diagnostic categories for thyroid FNA specimens. So, what was the advantage of Bethesda? Before the introduction of Bethesda, there was a non-uniform pattern of reporting. There was no mention about adequacy criteria and multiple category names were used. But after Bethesda, a uniform reporting system was introduced, which was unambiguous. The plan of management was, and the risk of malignancy was specified for each diagnostic category. So in short, it improved communication and provided a uniform template for sharing data among the investigators. The Bethesda system was further revised in 2007. This revision was inspired by new data and developments in the field of thyroid pathology. And this was based on the revised guidelines for the management of patients with thyroid nodules, the introduction of molecular testing as an adjunct to cytopathologic examination, and reclassification of non-invasive follicular variant of papillary thyroid carcinoma as NIFTP. So what were the changes between first and second editions of Thyroid Bethesda system for reporting thyroid cytopathology? The risk of malignancy were recalculated in the second edition of Bethesda system based on the post-2010 data. Since NIFTP was introduced, so the risk of malignancy was shown two ways related to NIFTP, that is risk of malignancy if NIFTP is considered malignant, and if risk of malignancy if NIFTP is not considered a carcinoma. Option of molecular testing was introduced for the management of AUS or FLUS and follicular neoplasms or suspicious for follicular neoplasms. Definition and diagnostic criteria for FN or SFN were revised in the light of NIFTP. So, because NIFTP had been introduced, cases with mild nuclear changes associated with PTC were now included in category 4. The definition and diagnostic criteria for PTC were modified to suggest limiting the use to cases with classic features of papillary thyroid carcinoma. Optional educational notes may be used for the subset of FN or SFN with cytomorphologic features suggestive of follicular variant of PTC or NIFTP. And an optional educational note may be used for malignant papillary thyroid carcinoma cases to acknowledge that a small proportion may prove to be NIFTP. So this is the Bethesda system for reporting thyroid cytopathology. So every report should begin with a diagnostic category. There are 6 diagnostic categories and every report should begin with a diagnostic category, and where possible a sub-diagnosis should be given in all cases. But if not possible, it is not necessary. So there are 6 diagnostic categories. First is non-diagnostic or unsatisfactory. Category 2 is benign. Category 3, ATP of undetermined significance or follicular lesion of undetermined significance, also known as AUS/plus. Category 4 is follicular neoplasm or suspicious for follicular neoplasm, abbreviated as FN/SFN. Category 5 is suspicious for malignancy and category 6 is malignant. So you can see 3 of these categories have 2 names: non-diagnostic or unsatisfactory, AUS/plus, and FN/SFN. So any of these two nomenclatures can be used in each of these categories. However, each lab should choose one of the names in each category. Both the names should not be used by the labs. For example, if you want to say non-diagnostic, you stick to non-diagnostic. If you want to say unsatisfactory, you stick to unsatisfactory. Both the terms should not be used by a lab. So each of this category is further assigned a risk of malignancy. You can see the benign category has risk of malignancy of 0 to 3%, whereas the malignant category has the maximum risk of malignancy up to 99 to 100%. And based on the risk of malignancy, the management of each category has been decided. All these are evidence-based management guidelines. So, for the benign category, follow-up is required. For non-diagnostic, you have to do a repeat FNA with ultrasound guidance. Molecular testing is required for AUS and FN or SFN category. And for suspicious for malignancy and malignant categories, near total thyroidectomy or lobectomy is required. So NIFTP, that is non-invasive follicular thyroid neoplasm with papillary-like nuclear features, this entity comprises 20 to 25% of the thyroid neoplasms, which were previously classified as malignant. So this has implicated for the risk of malignancy. So that is why the risk of malignancy has been shown in 2 ways by the revised Bethesda system, where the NIFT is not considered carcinoma and where the NIFTP is considered to be a carcinoma. And you can see there is higher risk of malignancy whenever NIFTP is considered carcinoma, especially in the categories of AUS, suspicious for malignancy, and malignant, because these are the categories where it is included. So this was about general discussion on Bethesda system. So now we'll be talking about the individual categories in the Bethesda system. So the first category is non-diagnostic or unsatisfactory. So the subcategories highlighted under this category are cyst fluid only, virtually acellular specimen, and other categories like obscuring blood obscuring the follicular epithelial cells, clotting artifacts, and drying artifacts. So when do you call a specimen non-diagnostic or unsatisfactory? We call the specimen non-diagnostic or unsatisfactory if it fails to meet the adequacy criteria. And what are the adequacy criteria? At least 6 groups of well visualized. Well visualized means we mean well stained, undistorted, and unobstructed benign follicular epithelial cells, and each group composed of at least 10 cells, preferably on a single slide. So this is the adequacy criteria. So as we have already discussed, a lab should use only one of these names whenever, and it should not interchange the names. Only one of these names should be used for one category. So it can either call the specimen non-diagnostic or unsatisfactory, and for every specimen it has to use the same nomenclature. So unless specified as non-diagnostic or unsatisfactory, FNA is considered adequate for evaluation. So for the non-diagnostic category, we have to mention non-diagnostic. For the other categories, we do not have compulsorily to mention that the FNA is diagnostic. For the category, suppose for category 2, we do not need to mention that the FNA is satisfactory because we have not specified it as non-diagnostic. So if you do not call it non-diagnostic, it automatically means that it is diagnostic. An explicit statement of adequacy remains optional. So these are some of the examples of a non-diagnostic smear. Here we can see a hemorrhagic smear, only RBCs are seen, no follicular epithelial cells or colloid are seen. So this is a non-diagnostic or unsatisfactory smear. In this photograph, we can see a skeletal muscle fragment. So this can be confused with colloid, but look for striations. You can see some striations in between. So this indicates this is a skeletal muscle. So this is an unsatisfactory smear. No follicular epithelial cells are seen. The diagnostic criteria are not met. This is a smear where you can see some follicular epithelial cells, but they are obscured by blood. So obscuration by blood is also one of the criteria for non-diagnostic smears. This is a smear which you can see this granular debris, and you can see these macrophages. So this indicates this is a cyst fluid. So you call it cyst fluid, but you are not seeing any follicular epithelial cells. Presence of cyst fluid only is a non-diagnostic smear. So as such, if you have a cyst fluid, there is very low risk of malignancy. If you have a simple cyst less than 3 centimeters, the risk of malignancy is very low. However, mostly we do not have any radiologic information. So in the absence of radiologic information, a possibility of cystic papillary thyroid carcinoma cannot be excluded. So the Bethesda has recommended that you keep this cyst fluid aspirated smear in non-diagnostic category and mention a non-diagnostic smear cyst fluid only. However, if the clinician feels that radiologically it is a benign cyst and there is no possibility of papillary carcinoma, he can treat it as a benign category. But pathologists should keep it under non-diagnostic category and mention the subcategory cyst fluid only. There are some exceptions to the diagnostic criteria which we are talking about. For example, in colloid nodules, any specimen that contains abundant colloid is adequate and benign. So in a colloid nodule, you can have abundant colloid, no follicular epithelial cells. So in that case, for the minimum criteria for follicular epithelial cells is not required, and the specimen is adequate, and you can mention it is an adequate smear, benign and colloid nodule. Then in case of solid nodules with inflammation, whenever you have a specific diagnosis, for example, lymphocytic thyroiditis, the number of follicular epithelial cells are not meeting the criteria for diagnosis. However, you have lymphocytes which are infiltrating the follicular epithelial cells, and you can give a diagnosis of lymphocytic thyroiditis. If you have multiple abscesses, follicular epithelial cells are less, but you have multiple abscess, sheets of polymorphs, you can give a diagnosis of thyroid abscess. It is not a non-diagnostic smear. If you have features of granulomatous thyroiditis, you have less number of follicular epithelial cells, but you have granulomas, you have inflammation, You can call it granulomatous thyroiditis in the benign category. It is not a non-diagnostic smear. Then third exception is if you have solid nodules with cytologic atypia. So whenever there is any significant atypia, you should not call it non-diagnostic, even if the follicular epithelial cells are lesser in number. You have to call it either in the AUS category, or depending upon the amount of atypia, you have to categorize it, but you don't call it non-diagnostic. So this is an example where you can see abundant thin colloid, cannot see any follicular epithelial cells, but this is an adequate smear and it is benign colloid nodule. Another example where you can see thick colloid with some scanty follicular epithelial cells. So even if they are lesser in number, we will call it a colloid nodule. So there's a note that solid nodules and partially cystic nodules with cytologic atypia should always be considered adequate, and they should be reported as abnormal, with a comment describing any limiting factors such as scant cellularity. This we have already discussed before. So what is the risk of malignancy in non-diagnostic categories? The risk of malignancy is 5 to 10%, and a repeat aspiration with ultrasound guidance is recommended for cytologically non-diagnostic or unsatisfactory nodules. This repeat FNAC mostly is diagnostic in most of the cases, but if the nodules remain persistently non-diagnostic even after ultrasound guided FNAC, excision is recommended in these cases. Coming to the next category, that is the benign category. So there are various subcategories under this category, that is consistent with benign follicular nodule, including adenomatoid nodule or colloid nodule, consistent with chronic lymphocytic thyroiditis in the proper clinical context, consistent with granulomatous thyroiditis, and others. So as we have discussed, the benign lesions are the most common lesions which are seen in a thyroid nodule, and benign follicular nodule is the most commonly encountered entity in thyroid cytopathology. So whenever we have a benign follicular nodule, it can include a number of entities which have similar cytologic features, like nodular hyperplasia in nodular goiter, hyperplastic nodules, colloid nodules, nodules in Graves' disease, and an uncommon subset of follicular adenomas which are composed predominantly of macrofollicular or normofollicular architecture. It is difficult to differentiate between all these entities based on FNAC alone. However, it is not necessary to differentiate between them because the management is same. So if you can differentiate, it is fine based on the clinical features and radiologic features. If you cannot differentiate, then also it is fine because the management is same. So whenever you have benign follicular nodule, you can have any of these entities and you can see if you can fit them into any of these entities. If you cannot, you can just give benign follicular nodule. So what is the definition of a benign specimen or benign follicular nodule? It is a cytologic sample that is adequate for evaluation and consists of colloid and benign appearing follicular cells in varying proportion. So first thing is it should be adequate for evaluation. The adequacy criteria should be met, and there should be both colloid and benign appearing follicular cells in varying proportions. So in some cases colloid can be more, in some cases follicular cells can be more, in some cases any of these may be absent also. So you have to look for the proportion, the adequacy, and for the proportion of colloid and follicular epithelial cells. So criteria: the specimen should be sparsely to moderately cellular. Very rarely it is highly cellular specimen. Mostly we get a sparsely to moderately cellular smear. And we saw we need to have colloid and follicular epithelial cells. So colloid can be watery or it can be thick colloid. Watery colloid on pap stain looks like a thin membrane or cellophane paper appearance. And in Remnowski stains, it gives a chicken wire appearance. And thick colloid on Remnowski stains gives a cracked glass appearance, whereas in pap stain it appears pinkish. Then when we look at the follicular epithelial cells may be arranged in monolayered sheets with a thin colloid in the background, or they can be microfollicular arrangement with a predominant macrofollicular arrangement. Some microfollicles may be seen, but they should not have significant nuclear overlapping or nuclear atypia. Thick colloid can also be seen, and here you can see monolayered sheets with some three-dimensional walls, but you can see the polarity in all these is maintained. Sometimes the benign follicular nodule can show extensive Hurdle cell change. So this is the oncocytic change. The Hurdle cells can show anisonucleosis, prominent nuclear layer. However, such neoplasms should not be labeled as Hurdle cell neoplasms. If you are seeing colloid in the background with Hurdle cell change, some benign follicular epithelial cells along with Hurdle cell change and background colloid, label it as a benign follicular nodule. Do not call it Hurdle cell neoplasm. This is the corresponding histologic specimen, which shows predominantly macrofollicular architecture with compressed Hurdle cell. So when we look at the benign follicular cells, they have a delicate cytoplasm with ill-defined borders. You cannot see the cytoplasmic borders, and the nuclei, they are evenly placed. There is no nuclear overlapping, no anisocytosis, and usually the size of the nucleus is that of the size of red blood cell. And you can have quadricolloid in the background. Sometimes the cytoplasm can contain hemosiderin or lipofuscin pigment, which looks golden brown. So most of the time it is considered that if this pigment is present, it is a benign follicular epithelial cell cluster. However, this pigment can also be seen in the malignant cases. So this is not a sure sign that it is a benign cluster of epithelial cells. Sometimes minimal nuclear overlapping and crowding can be seen, but there should not be significant nuclear enlargement or atypia. If there is significant nuclear enlargement, then they should be placed in category 3 at least. Sometimes these follicular epithelial cells, the nuclei can be stripped off, and then they may mimic lymphocytes. So this can be mistaken for lymphocytic thyroiditis. So these stripped off follicular epithelial cell nuclei should not be mistaken for lymphocytes. And when there is abundant thin colloid with suspended follicular epithelial cells in the colloid, the cells may dissociate and they may appear shrunken and spindle shaped. So this artifact should be known. In some nodular goiters, cystic degeneration can occur, and this cystic degeneration in cystic degeneration, you can see abundant macrophages along with follicular epithelial cells. Colloid can be present and granular material will be present. So this is a case of colloid goiter with cystic degeneration. In some cystic neoplasms, you can have focal reparative changes in some of the follicular epithelial cells. Here the cyst lining cells, they will appear they will show atypia. They can have enlarged nuclei, granular chromatin, and they can have spindle-shaped or squamoid appearance, which is known as tissue culture appearance. So these changes should not be mistaken for malignancy. However, if extensive changes are seen with nuclear clearing, grooving, then a possibility of malignancy should be ruled out. And if there is extensive atypia, they can be kept in the category of atypia of undetermined significance. So now we'll be talking about some of the diseases which come in this benign category. First is the Graves' disease. It is also known as it is an autoimmune disease where there is diffuse enlargement of the thyroid, seen usually in middle-aged females, and patients have hyperthyroidism. The patients present with diffuse enlargement of thyroid gland. Cytologic features are non-specific, and for the definitive diagnosis, clinical correlation is required. Aspirates usually are cellular and they show similar features to non-Graves benign follicular nodules. So this is a cytologic smear of a case of Graves' disease. You can see the cells arranged in monolayered sheets and they have abundant foamy cytoplasm. You can see these flame cells with pinkish cytoplasm. Marginal cytoplasmic vacuoles can be seen and pink edges are pinkish and frayed. The nuclei they can be enlarged, vesicular, prominent nucleoli can be seen, and isonucleuses can be seen, and the cytoplasm has a oncocytoid appearance. Sometimes in case of Graves' disease, follicular cells they can show chromatin clearing, grooving, and however other features of nuclear features of papillary thyroid carcinoma will be absent and isonucleosis can be seen. So these cases should not be mistaken for papillary thyroid carcinoma because these changes will mostly be focal, they won't be diffuse. Some cases may have got prior radioactive iodine therapy. So it is important to take this history of radioactive iodine therapy in patients with Graves' disease because in these patients there can be prominent microfollicular architecture, significant nuclear overlapping and crowding, considerable anisonucleosis can be seen in these cases, and they can be misdiagnosed as malignant or neoplastic. So history is important. Treatment history is important in these cases. The second entity we will be discussing is lymphocytic thyroiditis. The most common cause for lymphocytic thyroiditis is Hashimoto's thyroiditis, seen mostly in middle-aged women with diffuse thyroid enlargement, and FNAC is done when they develop nodularity or an increasing thyroid volume. These cases are associated with circulating anti-thyroglobulin and anti-thyroid peroxidase antibodies. So what is the definition for these cases? A cytologic sample for lymphocytic thyroiditis. Cytologic sample composed of many polymorphic lymphoid cells associated with benign thyroid follicular cells and or Hurdle cells. Okay, so you should have lymphoid cells which are polymorphic, not monomorphic, with benign thyroid follicular epithelial cells, and we can have Hurdle cell change in these cells. So this is a smear of lymphocytic thyroiditis. We can see a Hurdle cell change, benign follicular epithelial cells showing extensive Hurdle cell change, and many lymphocytes in the background. Hurdle cells, they have abundant granular cytoplasm, prominent nucleoli can be seen, and sometimes marked anisonucleosis can also be seen in these Hurdle cells. This is the LBC smear. So in LBC smear, it may sometimes be difficult to interpret the lymphocytes. So you have to look carefully for the background lymphocytes, and these can be sometimes they can be infiltrating in the benign follicular epithelial cell clusters. In some samples, there can be a predominance of Hurdle cells. So in these cases, the differential diagnosis of suspicious for follicular neoplasm can be kept. And sometimes lymphoid cells can predominate in an aspirate. So these cases may be confused with a lymphoma. If you have a monomorphic aspirate, then go for flow cytometry to rule out a lymphoma. Then we can have granulomatous thyroiditis or decurvaceous thyroiditis. It is a self-limited inflammatory condition of the thyroid, which is believed to be triggered by a viral infection. So you can see epithelioid histiocytes, mixed inflammatory cells, and along with benign thyroid follicular epithelial cells. So this inset is showing the epithelioid collection of epithelioid histiocytes. And acute thyroiditis is very rare. It is a rare infectious condition of the thyroid, mostly seen in immunocompromised patients, where you can see marked inflammation in the thyroid. You can also find some causative organisms in immunocompromised patients, especially. Reeder's thyroiditis is a rare form of thyroiditis, which can result in progressive fibrosis of the thyroid gland with extension into the soft tissue of the neck. So, it is believed to be a manifestation of systemic IgG4 related disease in the thyroid. So, clinically, patient will develop with a hard fixed thyroid mass, which can simulate anaplastic thyroid carcinoma or lymphoma. So whenever you have a patient with a hard mass of the thyroid, which is fixed to the surrounding tissues, you have uh, you should keep two possibilities of carcinoma, anaplastic carcinoma, or it can be a case of Riedl's thyroiditis. So if it is a rapidly developing lesion of a few days history or a month's history, possibility of anaplastic carcinoma of thyroid is more likely. So aspiration smears in Riedl's thyroiditis, usually because there is fibrosis, it will be scanty cellularity. You can see some bland spindle cells, some chronic inflammatory cells, and only some follicular epithelial cells. The risk of malignancy in the category 2, that is benign category, is 0 to 3%. So there is very less chances of malignancy in these cases. And according to 2015 ATA guidelines for the management of thyroid nodules, it is recommended that no further diagnostic studies or treatment is required for the benign cytology. However, follow-up can be done, and it should be determined by risk stratification based on the ultrasound pattern. So in case of nodules with high suspicion ultrasound pattern, repeat ultrasound and ultrasound guided FNAC can be done within 12 months. If there are nodules with low to intermediate suspicion ultrasound pattern, you can repeat ultrasound at 12 to 24 months. And if you have nodules with very low suspicion ultrasound pattern, the utility of surveillance ultrasound is limited. And if you have to repeat an ultrasound, it should be done at after 24 months.